Assalamu alaikum and good afternoon. So I just talk on very different issues. Actually, the high dose radiotherapy for the prostate, particularly the interstitial brachytherapy in the low resource setting. In our country, we have done one cases, particularly in our hospital, in Square Hospital. I try to just tell about the story and how we do it, actually how is it workable, that's the thing. So here actually we can see here the prostate is a health issue, not only the man, the Western countries also for the worldwide, and especially considering the recent epidemiological trends. And particularly this is also frequent in our country as well, though the information in the Globocan and other information we feel actually it is undermined and there's not a proper real information because we don't have any cancer registry in our country. But the Professor Salam always say that actually, he is here actually, the number of prostate cancer is more higher than we have every day we get this data. So this is important for us. So the global situation overall, so South Asia. So this histology, we know everything actually, prostate, everybody knows what is going on and what the prostate, other things. There is staging, we know the staging of prostate cancer. So this is the risk stratification, particularly I am interested for the very low and intermediate favorable and high, particularly for a high risk patient because I am looking for the discussion about the high dose rate prostate brachytherapy. What are the treatment options? The optimal management of the both localized and the locally advanced the prostate cancer remains controversial. Locally advanced prostate cancer remains controversial because the surgery, radiotherapy, and the hormonal therapy can be used in the alone or in combination to treat the different risks. So dose escalation 70 gray has been proved to be beneficial. So many doses, different doses are there. Many guidelines from particularly we are following some guidelines from the UK Royal College of Radiology. So many guidelines. So very different things. So I'm particularly talking about the dose escalation can be performed either with the conformal EVRT with brachytherapy using the temporary iodine iridium 192 or the permanent 125 iodine or 130 polonium, so C implant. This seed implants actually not available, is very costly. So we try to have a iridium 192. The external beam radiotherapy and interstitial brachytherapy also can be used alone or in combination to take advantage of their unique attributes. The technological advance in the real-time ultrasound image guidance for the high dose rate prostate brachytherapy has placed this treatment modality at the forefront of the innovation in radiotherapy. So you know that actually HDR combined with external beam radiotherapy results in the higher control rate than the external beam only and should be offered to eligible high and intermediate risk patients. Not only that, actually we can give it actually particularly for the very low risk and intermediate favor as well. HDR 1200 centigrade per hour brachytherapy can be used as a boost to the EVRT as a monotherapy as salvage therapy treatment as well. HDR implementation can be performed before or after the EVRT because an insignificant prostate volume change is expected. While the variety of the dose and fractionation have been used in a single 15 gray HDR combined with the 40 to 50 gray external beam radiotherapy results in a disease-free survival of over 90% of for intermediate risk and 80% of the high risk. So this is actually important how the things happening. So the advantage of HDR results in more consistent dosimetry than that's seen with LDR, with less variability in target coverage and lower relative dose to the urethra, bladder, and rectum. Dosing outside the prostate to cover the extra prostatic extension of disease and seminal vesicle invasion is more reliably achieved with HDR. The short treatment time is also provides a possible advantage in using the HDR to treat more rapidly dividing cancers. The mean alpha beta ratio for the prostate cancer is very low, which is even lower than the adjacent normal tissues and would suggest the prostate cancer cells are more sensitive to radiation delivered in a large fraction size than the normal late responding cell. So the rapid delivery and the high conformity of the dose results in lower toxicity than that is seen in the low dose rate implants. The very different duration of the treatment delivery between the HDR and LDR results in quicker resolution of the urinary symptoms following HDR. HDR as a boost, the most common application for the temporary BT is to use a local dose escalation method is complementary to the external beam techniques, and the combination allows lower normal tissue doses in the surrounding tissue and a very high local dose to the tumor. This treatment is indicated in intermediate or high risk cases that do not have the nodal involvement of the metastasis. There is no consensus on the timing of HDR brachytherapy in relation to the EBRT and the effect of the sequencing on patients. Long-term follow-up data confirm that HDR boost combined with external beam radiation results in excellent biochemical control rates. What is the advantage actually in the low-dose setting? The HDR after loaders are versatile and suitable in the low-resource setting countries. Radiation dose is rapidly delivered over a matter of minutes rather than slowly over weeks or months as LDR. The cost of the radiation source and workforce in the HDR treatments is stable, while the growing number of the implanted seats per se for the each patient continues to add up in LDR. The temporary brachytherapy using a stepping source does not need any source preparation time and causes no post-implant radiation protection problems, no target movement during radiation. It also allows fractionated treatment schedules as well as individual dose optimization and high delivery quality assurance. Introducing a remote control loading technique combined with the technological development in sonography devices as a transrectal ultrasound as well as the treatment planning software development results in an appropriate target delineation and guidance of the needles. Truss-guided transperineal template are using, particularly we are using the develops in the remote after loading the brachytherapy device and technology as well as the transrectal sonography result in the highly sophisticated tools in the field of the interstitial treatment of the localized prostate cancer. This is widely consensus today that truss-guided transperineal template implant techniques present with the standard of interstitial prostate brachytherapy with an accurate needle placement. So the real-time image, the good image quality of the prostate boundary, the clear visualization of the needles, we can get it. So glands over 60 cc at the time of implantation are often technically more difficult to implant, larger than. So because of this pubic arch interference and because they require a large number of seats, these patients often become good implant indicate for the cytoreduction with the hormonal therapy. Hormonal deprivation prior to the radiation likely to decrease cancer cell burden and may cause an increase in the local cancer control. Neoadjuvant hormonal downsizing prior to the radiation has also shown a 30% reduction in the prostate volume. Approximately 3-month course of the neoadjuvant utilizing hormone we have given particularly for this patient, reduction in 30 to 35% of the enlarged prostate. So these are the potential indications, histologically proven, localized and locally advanced prostate cancer with a volume of the gland smaller than 60 centimeters cube with a distance to the rectal mucosa greater than 5 millimeter with no evidence of the metastatic disease or computed tomography, magnetic resonance. So these are the clinical staging and how we can looking for the comparative cases and T2A or the PSA greater than 10 nanogram. These are the contraindications. In the IPSS score is more than greater than the 20. So this is important. So we have actually this case we found is our patient tumor profile. It was 3C, moderately hypotensive lesions involving the peripheral as well as the transitional zones from the apex to the base, and extra prostatic extension in the left posterior and the infiltration into the left seminal vesicle. So T3B and not M not, and the prostatic adenocarcinoma grade 5, group 5 and Gleason 9, prostatic volume was 19 cc, PVR 125 and IPSS score 6. Initial PSA was 74.8, before brachytherapy PSA was 0.66. So pre-treatment actually generally other thing, we are doing the same thing as well. Our clinical team was a big team, big team, urologist, oncologist, radiologist, medical physicists, anesthesiology, OT staffs, nursing staff, so many big things. We have the Professor Salam also with us, so one of the so the required equipments are, so one of the important equipment is truss, but unfortunately we don't have the very specific truss available in our country because it's very costly, so we try to the conventional one in our country. Patient preparation, as well, patient started with the androgen deprivation therapy 2 months before the brachytherapy, was recommended to continue androgen therapy for total of 2 years, and single fraction treatment was planned, and consent was, etc. So the procedure was done in generally the dorsal lithotomy position, and so other things are going on, rectal probe inside in the rectum. So procedure was done. I can show you some photos, how do we doing things. This is Imtiaz. Actually, he's a uro-oncologist of radiation uro-oncologist of UK. So he was one of our guidance for this whole program. So this is the template you were using. This or this. So we also perform the CT simulation, single fraction HDR boost. Treatment planning was we do the 20 needles. Each needle was meticulously constructed, dual position spaced 5 mm apart in the PTB. Single fraction dose of 15 gave was prescribed for 100% of the isodose, targeting coverage of more than 95% of the planning target volume with 100% of the prescribed dose. So the dual times were adjusted to ensure the organs at risk remained within the tolerance limit, allowing for a potential reduction of the coverage. So you see the planning. So this is the dose volume histogram. Treatment delivery was done, needles connected, etc., etc. Status of our patient after procedure is absolutely fine, no significant subcutaneous hepatoma, even ecchymosis observed. Within 90 days after the brachytherapy, perineal pain, some problem was there, retention, but finally it was managed. The quality was absolutely fine. Analysis actually, absolutely the patient, some problem was urinary frequency, dribbling, mild, but finally it was absolutely picking up the 3 and now is absolutely fine. So the clinical, everything was absolutely under control. The post-treatment whole MRI, say normal prostate with the features of fibrosis, both lobes, no residual tumor is noted, capsule appears intact. Biochemical control, pre-treatment was 74.8, now is 0.66, PSA after HDR, brachytherapy after 3 months was 0.77, 5 months 0.034, 8 months after 0.01, testosterone 0.08 after 8 months. So this is my patient, and basically he is my class friend from Chittagong, because I am also from Chittagong, my school friend. So he agreed to come forward with this. Absolutely, well, I'm also grateful to Professor Salam and other who is supporting us, the big team. Otherwise, it was never possible. Thank you for patience hearing.